Okay, we get to prescription number 3, a mindset change, moving from system 1 to system 2. Now, what does this mean? As a doctor, you have trained yourself to rely on your instincts. The large vocabulary of insights and knowledge that you've gained from your experience. When there is an emergency and you're faced with imminent morbidity or even possible mortality, the doctor's instinct kicks in, almost exactly like a high performance athlete. You can anticipate the trajectory of the disease in your patients, like let's say Roger Federer, who could anticipate where the tennis ball will be returned. Doctors, given this training, this practice, and the situations that they deal with, are trained to move swiftly, to behave like high performance athletes. This instinct and this capability is, I think, embedded into the psyche of our doctors, and is probably second nature to them. And it suits and works very well for the doctor and their patients. Senior doctors make decisions that are immediately carried out. Things happen quickly, and bureaucracy in implementing decisions is not an option. There are no endless debates and no paralysis analysis discussions. All this until the doctors meet with hospital administration. Everything seems to slow down, and the management boardroom seems like a time warp. The doctor might as well feel like he or she is entering a parallel and a strange alien universe where everything seems to move in ultra slow motion. You see, administrators deal with complicated and sometimes even frustrating bureaucracy. Decisions are centralized. Multiple approvals are required before a decision can be implemented. And mind you, management decisions have serious implications for many people's roles and security. And there is no telling how each individual or group might respond. Also, there are several stakeholders within the hospital ecosystem, as we saw earlier, and they all have conflicting agendas and goals. So any decision that management takes must be carefully weighed and calibrated. Also, financial scenario and financial sensitivity analysis are needed. This takes time and requires more approvals. So doctors, no wonder, they can't seem to quite get why a decision to improve good outcomes requires endless meetings and time. This contrast between cultures in the procedure room or in the doctor space versus the boardroom may partially explain the reasons for conflict and the frustrations that the doctors might experience with administration and vice versa. So what can doctors do? Shift your mindset. Reflect. Could the instinct that the doctor developed within their clinical practice probably come in the way when engaging with administration? Could this be the case of two contrasting worlds colliding? If yes, then I suggest you disarm the administration and management. How do you do this? My dear doctor, the next time you walk towards the administration wing, which is generally characterized by carpeted floors, generously upholstered interiors, the constant whiff of coffee, and suited men and women twiddling their pens, sitting around polished mahogany oval tables, take a step back. You adopt a different attitude. Change gears. Change mindset. Adopt an almost Zen-like attitude. Consciously move away from what is natural and instinctive to you. Move to a mental state that is more deliberated, more computative, and more calibrated. A colder and a more measured approach. A process that is trained to look at numbers and statistics. Put on a poker face, doctor, and disarm the board by admitting the efforts you're making towards contributing better to the board and by making this mind shift change. Please remember, managers and all those guys sitting there in fancy suits can never do what the doctors can. But the doctors can equip themselves to do their jobs or at least influence them. And never forget, every dollar of revenue that a hospital makes is a direct result of the doctor's decisions on patient care plans, etc. Hospitals are and hospitals will always be about doctors and patients, not about operations managers, finance controllers, strategic advisors, and other bean counters. Right? So, in order to help doctors make this mindset shift or mindset change, I would like to lean upon a study, a seminal study, a work done by Professor Daniel Kahneman, Nobel laureate Daniel Kahneman. His book, Thinking Fast and Slow, is a masterpiece. His contributions to behavioral economics and utility theory are so significant and so far reaching. I would very strongly recommend that you get a copy and read this. There's no substitute to reading it, but let me try and outline parts of that which are relevant to us in this recommendation on mindset. So Professor Kahneman introduces the idea of S1 and S2. System 1, I call it ATP, automatic thinking process, and system 2, I call it DTP, the deliberate thinking process. Let's look at this. So the brain location. So when it comes to system 1, it mostly operates from the limbic system, whereas system 2 operates from the neocortex. The velocity of decisions in system 1 is very quick, is almost unconscious. You don't even know the decision is being made. Whereas in system 2, it is slow, painful, and torturous. The thinking type is intuitive in system 1, rational in system 2, qualitative in system 1, scientific in system 2, and pattern-oriented in S1, and very deliberate and computative in system 2. The decision-making type is generally simple. The decision-making type in system 2 is complex. You're largely unconscious when you're in your system 1, whereas you're utterly conscious and you're paying a lot of conscious attention when you're in system 2. The effort level is very low in system 1 because you barely use any energy. You don't even know the effort is happening. It's happening behind the scenes, whereas it's very high with system 2. However, the error rates in system 1 is very high. System 2, the errors of your decision making and the outcomes is probably a lot lower. The characteristic is that this is associated in terms of how decisions are made, whereas in system 2, it's very analytical and computative. What's the advantage? System 1 is fast. What's the advantage of system 2? System 1 is accurate. The disadvantage? System 1 is biased. System 2 is slow. System 2 uses a lot of glucose. So due to these reasons I indicated at the beginning, and I said that doctors, because of their instinctive nature, almost like high-performance athletes, I assume that they might tend to more naturally reside and operate from system 1 or ATP, automatic thinking process. Right? Now, due to their insights and the knowledge of human anatomy and system progression, the doctor's system 1 is deeply integrated with their intuition. However, when it comes to matters like management and economics, doctors may not have that same capability. And therefore, the doctors need to make that effort to make the shift when they're dealing with management. So when they go from the procedure room to the boardroom, move from system 1 to system 2. And system 2 emanates from the neocortex or the rational thinking brain, whereas system 1 resides in the limbic system or the emotional brain. Right? And as we discussed, system 1 is quick and efficient, but it is also shallow and erroneous, whereas system 2 is more accurate. Also, system one tends to believe things that are easy to believe, whereas system two does the job properly, but it uses a lot of glucose. The biggest danger and disadvantage of system one is that it makes us vulnerable to our biases and prejudices. And when you're dealing with management and administration, and there are so many different stakeholders and so many different complexities at play and so many different agendas at play, you need to take a step back and compute and calibrate the outcome of every decision you take on all of those associated stakeholders. Right? So the ability of doctors to alter their mindset and activate system two, I think, can be an extremely important weapon in their armory, especially as we are calling upon doctors to lead, to influence organizational decisions, to influence governance, and to influence policies. But there is a big but. There's a very, very big but. And we will get to what is this but in the next question.